the labor or push the labor along by breaking the patient's water. What do you think is happening in the body that would cause contractions to increase after the water's broken? Any ideas? Because it certainly increases dramatically. After your water breaks, your labor really picks up pretty dramatically most of the time. There are some rare cases where a patient's water breaks and nothing happens, but that's less common. And usually in that case, they weren't in labor at all anyway. Okay, so here's what happens. So think about the uterus. What we know with the uterus, remember the uterus is a big muscle, like a balloon, and it's a big muscle, and it's squeezing. Inside of that big muscle is the amniotic sac, which is a fibrous membrane, and encased in that membrane is amniotic fluid and the baby and the placenta. So as that uterus squeezes on that big sack of water, it's meeting resistance, and that's kind of protecting the uterus from contracting really strongly, right? Because that bag of water creates resistance. If we break that membrane and all that fluid's gone, that cushion that was there is gone. So now the contractions can squeeze directly on the baby and really be more effective. So can you see how all of a sudden they would get stronger without that tough, it's like a balloon within a balloon. And that internal balloon, which is the amniotic sac, is preventing the contractions from really being able to do their job. So once the water breaks, it kind of takes off without that sac there to cushion the blow, so to speak. So it certainly picks up after, if someone's already contracting, labor will certainly pick up after that. The what?
What's the A and A wrong?
Artificial. Mm-hmm. So if the AROM is done by a doctor, the doctor comes in, or midwife, breaks the patient's water, we certainly will document the time it happened, assess for amount, color, odor. Amniotic fluid should not smell. If it's about smelling, then that's concerning. They're concerned about infection. If it's brown or green, what's going on? What's in it? It has meconium in it, which means the baby had a bowel movement in the amniotic fluid. That we'll talk about in detail in the next chapter of what the significance of that is. But we certainly would note that if we see a brown or green color to it. So after the doctor breaks the patient's water, provide hygiene, keep the patient clean. Fluid may continue to leak, so they're going to make you feel uncomfortable and not clean. Document the amount, color, odor, time. But the most important thing of all that you do after the water's broken, the priority is to observe the fetal heart rate, especially right after the doctor breaks the water. This is why. Once again, it was Sarah's patient who had a cord prolapse last week or the week before last, whenever it was, weeks ago. So, had they just broken her water, Sarah, or not? Was it remote from that, or?
They went in to break her water, and then when she got in there, it had already.
It happened more spontaneously. It wasn't really related to that then. Okay. So, if we think about, and I don't have my pelvis with me today, but if you think about the pelvis and where the baby's head is, if this is the pelvis and this is the cervix, which is the door of the uterus, if the fetal head's right tight against it like that, and the water breaks, usually all's well, nothing bad can happen. But what if the head's high up and floating a little bit? Okay, now they break the patient's water from down below, and it kind of, what happens is almost like, when you pull your plug on the bathtub, it's kind of like a suction, like a little bit of a vacuum, and water starts to just pull out. Same thing sort of happens. You sort of see a gush of water come out, and if the head's way up here and there's nothing plugging that opening off, then what can happen is the umbilical cord can kind of come falling down too from that pressure, and the cord can fall out past the baby's head and down into the vagina. That's called a cord prolapse. Basically, now the umbilical cord is coming ahead of the baby. And what happens is the head will pinch the cord off, and then you have no circulation to the baby. So that is a OB emergency, cord prolapse. In the case of Sarah's patient, they did exactly what they're supposed to do. When you see the heartbeat drop, usually when it's close to an amniotomy, if it's right after, a nurse typically, she's the one in the room, checks the patient, tries to feel for the cord. If they feel it and it's not pulsating, which would mean, it's beating and all's well, if it's not pulsating, then they try to push the head up or push the cord away from the head in such a way that it starts to pulsate again, and you stop that squeezing of it. And then that person has to stay in that position until they get to the OR. They do an emergency C-section and have a baby. And as you all somebody else is at the desk too, I can't remember who else at the desk, but you all remember there's somebody up in the bed with the patient, essentially holding the head up off the cord. And she said, I have a good heart rate. I can feel I can feel the cord pulsating. It's okay. But she had to stay there in that position until they get to the OR, put the patient to sleep, do an emergency C-section.
I don't guess the baby's heart rate ever dropped dramatically.
Well, that was a kind of
they did a timeout and everything before.
That was a little more odd case. Typically, in the typical cord prolapse that happens right after an amniotomy, the doctor or midwife breaks the water, and then within 10 minutes, the heart rate drops suddenly. And then the nurse checks the patient, the heart rate's down, she feels the cord that's either pulsating or barely pulsating. They push the head up off the cord, stay there holding that cord until they get to the OR. So yes, that case is a little different in that the cord came down, and they found it, I guess, when they checked the patient, but it wasn't causing a problem, and that's very rare. But cord prolapse is considered to be an emergency, and it will get you an emergency C-section right now. So after the water's broken, all those things are true and good, and we will do them. Assess for amount, assess for color, assess for odor, document time, provide hygiene. But the most important priority thing that you do is this: observe the fetal heart rate after an amniotomy, because that's usually when that cord prolapse is going to happen, right after the water breaks. Because again, there's sort of like a vacuum for a minute when you first break the water, and water comes kind of gushing out. And if the head is not up against the cervix, then the cord can come right down beside the baby's head, or past the baby's head. I think in the next chapter I actually have a picture of it. We'll talk about it a bit again. Does everybody understand that? Any questions about that? Does it make sense? This is one of those emergencies. It's easily resolved. I was going to say you call it easily by an emergency C-section, but you got to act quickly. You don't want the baby heartbeat to be down for too long, and you have to identify it quickly. So what are other potential problems besides cord prolapse? What are other potential problems that can happen after the patient's water breaks? Well, because of the concern of infection, once anyone's water breaks, whether it's spontaneous or whether it's done by the physician or midwife, we check their temp every 2 hours until birth, until they deliver the baby. Temps every 2 hours until birth. Because we are concerned about infection, we'd like to get the patient delivered within 24 hours. And, all day, all night, we're going to watch their temp very carefully. And then, of course, cord prolapse we already talked about. So, of all the things we do, the most critical action is to assess the fetal heart rate and watch for signs of a cord prolapse. Everything else is important, but that's the priority. And like I said, I've got a couple pictures in the next chapter. We'll show you that talk specifically about cord prolapse. Okay, so we talked about managing labor, determining true labor. We talked about when the water breaks. Now, the patient's in labor. What are other things, nursing responsibilities during the first stage of labor? Remember, the first stage is from the beginning of labor till the patient's completely dilated. The longest stage varies the most in length. General hygiene, frequent peritoneal care are must. Patients may be bleeding, they may be leaking amniotic fluid. The thing that just used to make me crazy, go into a patient's room, they sit in the same soaking wet chucks that they've been sitting on for the last 4 hours because nobody changed their chucks and, kept them clean. Very uncomfortable and, not okay. Nutrient and IV intake. Most patients are NPO except ice chips. They are sometimes giving them clear liquids now when they're really early while they're still comfortable. Sometimes they'll give them clear liquids if they're low risk. But typically across the board, NPO except ice chips is usually the standard. IV fluids are going to be getting what kind of IV fluids? Anybody having a baby is going to be getting what kind of IV fluids? Lactator. That's your maintenance IV. Always, always, always. Elimination. Urinary elimination usually is able to be accomplished by the patient until or unless they have an epidural. And then you're going to have to straight catheter or put a Foley in, because once they get an epidural, they cannot feel to empty their bladder. They're going to become very distended very fast because we're giving them tons of fluid for that epidural. So they're going to fill up quickly. As far as bowel elimination, if a patient goes into labor on their own, very frequently they'll have a natural emptying of their bowel at home. If they're induced, sometimes it doesn't happen the same. We used to, way back again when I first started, we used to do enemas on every patient. That was like the standard. Got in on the hospital. And one doctor who's retired years ago, and he used to write, when we started getting away from that one of the orders used to be in admission, half prep and enema. And half prep basically means you shave the patient's belly all the way down to the mons pubis, every patient. That's ridiculous. It's not necessary. If you don't have a C-section, there's no reason you need to shave any hair at all or anywhere. And so, but we used to do that. And so they would write an order for half prep and enema, and so we started getting away from that. And we started being progressive and not doing that anymore. So we used to write in parentheses, not an option, because he would get mad because we weren't doing it. Because nobody was doing it, but he wanted all his patients to have that. So an enema, while some patients might appreciate it, they've had some trouble with constipation and difficulty emptying. Most patients, again, if they're go into labor, have a natural emptying of their bowel before they even go into labor. It's just sort of something that happens. Ambulation and positioning, we talked about this a little bit in the last chapter, but we certainly want to encourage frequent position changes as long as the patient is able before she gets an epidural. Once she gets an epidural, she's going to be very limited. But before that, anything that she can position with, she can get in that's comfortable, we want her to do. If she wants to lean over the side of the bed, she wants to use one of the birthing balls and bounce on that big rubber ball, which for some reason seems to be very comfortable for patients. She wants to walk around as long as the baby's heartbeat's okay. Even if she's on Pitocin, we can let her walk around the room a little bit and just keep the monitors on her belly. She doesn't have to have continuous monitoring if she's on PIT, but as long as we can get them to move, we need to do that. What benefit will that have on the position of baby as well? What we learned on Monday about position of baby and moving your patient? That's beneficial, right? Mm-hmm. If the baby gets in an occiput posterior position, which we don't like, we want it to be in an occiput anterior position, the best way to get the baby to move is to move your patient. Move your mom. Again, usually the best way to get the baby to move is for her to get, put her chest down, so she can lean over the side of the bed, or she can get on her knees, whatever's most comfortable, but that's the best way to get the baby to flip. And all that is great until they get an epidural. And then we have to put them flat in bed, head of bed up 30 degrees, left side, right side, left side, right side. So then their ambulation and positioning is extremely limited after that. And there's just a picture of a patient on that ball, and she's in the position that we would like to see a patient get in if her baby's occiput posterior. Will help the baby to flip. And they're just using a Doppler to listen to the baby's heartbeat while she's leaning on that birthing ball. Labor support can be provided by the nurse, by the significant other, whoever that may be, by doulas, by other family members. You all know what a doula is? Anybody not know what a doula is? A doula is just a trained labor coach, basically. They're not typically nurses, although they could be a nurse. They're not typically nurses. They're lay people who are trained to coach labor. And most people find them very helpful to a patient in labor because they know, just the right place to touch it, just when just when you want to be touched, just when you don't. They just seem to have a knack for that because they've done it a lot. If you're lucky enough to have a nurse that you're their only patient, then you may get a lot of those same advantages from your labor nurse as well. What about siblings during the labor and birth? So we have to think about how, like mom has 2 teenage children. She wants them to be there for the birth, or 2 school-age children, and she wants them to be there for the birth. So first of all, we have to consider the age. We have to consider what's going on with the labor. Is this a normal labor, or is it a problem-filled labor? What are we going to expect them to see? Teenagers is probably a good thing. Probably a great thing for a teenager to see a baby born. Maybe it would be birth control. I don't know. at CAMC, and every hospital is different, but at CAMC, if they're younger than 10, if they're older than 10, it's just, it's discretion of the, the nurse and physician, that's typically okay. But if they're under 10, they have to have a special education and watch a movie, and there has to be one dedicated person that's responsible for that child beside the patient support person. So, like, the patient's husband's there, and he's got two kids, 6 and 8. If something happens and you got to get the kids out, well, if he's responsible for the kids, he's got to go too. There goes the patient support person. So we have to have a dedicated person for each child, separate from the support person in case they have to leave. And they have to agree and sign that if the staff deems that the kids should need to leave, they have to willingly leave. And they have somebody that's they're responsible for taking care of them. So we do send them out if there are emergencies typically and things that we consider that might be difficult for them. What I found is children are very stressed by seeing their mom in pain. Seeing their mom cry in pain or be in pain, that's very stressful for kids. So I would think really hard about that. Not saying it's not okay. People that have home births, their kids are all right there. I've seen videos where kids are in their mom's face, mommy, mommy, mommy. What's wrong? And if that's okay, if that's what works for somebody. But I have seen children and seen them be very stressed. And the older the kid is, it seems like the more stressed they are. I think really little kids don't get it. They don't quite understand what's going on with their mom. But the older they are, the more stressed they are because they see their mom in pain. So I think those things are things that need to be kept in mind as well. And the most important thing is that we make all this clear beforehand. We don't wait till the birth to start discussing this. If that somebody wants their family nurse, this needs to be discussed in advance, planned out in advance, so that we can all be on the same page about what the policies are. At a birth center, you're going to see a lot more flexibility than you are at a hospital. But remember, a hospital is different. A hospital is where surgery occurs, is where you go when there are complications. Birth centers are for normal risk, very, very low risk patients, and then a home birth, of course, even lower risk. All right, so that's the first stage of labor. Let's talk about the second stage. So the second stage begins at complete dilation, 10 centimeters, right? And lasts until the baby is born. So during the second stage, that's the pushing stage. That's really the work stage for the patient. During the first stage, everything's sort of happening to them. They're experiencing the labor, but they're more passive in this process. In the second stage, they're active participants. If they don't push, the baby's not coming out for the most part. So there are two possible parts of the second stage. The latent phase would be if the patient doesn't push and you just let the head descend naturally. And the active phase is when the patient's pushing. So 99 times out of 100, we're going to have the active phase where the patient's pushing. The exception to that is if the patient has an epidural and they're so numb, they feel zero urge to push. And if they feel zero urge to push, you don't benefit by having them push. You just tire them out, and they're not making much progress. So I think I told you this before, but we turn their epidural down, let them rest for an hour, let the head passively descend. It'll descend somewhat on its own, not as much as it would if you're pushing, of course, but it will have some descent. Let the patient's sensation come back and then start to push. And these pictures just start to show as the head begins to crown. When we say the word crowning, that's what this means. Is when the patient's pushing, you can see the head. A little more. And it's over on the very last slide. That's the baby's very close to being born at that stage. So for first babies, the average pushing time is between 1 to 2 hours for first baby. For second, third, and subsequent babies, it's wildly varied. It could be 3 minutes. It could be, again, an hour or two. If they're having a much larger baby than their first baby, let's say their first baby was 6.5 pounds and now they're having an 8.5 pound baby, they may have to push like a first time mom because they're having a very much larger baby. Or, let's say maybe their baby's a pound smaller than it was the first time. They may push with 2 contractions and out comes the baby. Sometimes with some of these multips, the doctor barely gets there and you're begging them not to push. Don't push, he's coming. And the doctor's coming, I promise the doctor's coming. And so we try our best to hold them off until the doctor gets there. Sometimes in spite of our best efforts, does the nurse deliver the baby? Yes. That's not ideal and that's not desirable, and doctors are not very happy when that happens. But I kind of feel like they know. It usually happens to a multi who's had several babies and always feel like you knew that was her third baby. You knew she was 8 centimeters. That's on you, not on me. So, but we do our best, and that's why doctors like epidurals. One of the reasons because you've got a lot more control. They're not as apt to push that baby out because they don't have as overwhelmingly an urge to push it without an epidural. This picture is of the birthing bed, and the birthing beds are regular beds that you know look like a regular hospital bed, but they break down and do all kinds of different things. So you can see how the foot of the bed goes down, and you can put the patient what we call the foot pedals up here or the stirrups here. I will say 9 times out of 10 for birth, we go ahead and put them up in stirrups, which is called lithotomy position. You can also use these foot pedals where they just set their feet, but what happens if they have an epidural, especially if their legs are up, they just kind of just fall together, and it's hard to get, it's hard to keep their legs out enough to be able to deliver the baby. This is the birthing bar. I think I talked about this in some of the clinical groups. Again, a great thing for a patient whose baby's OP because they're leaning forward and it helps the baby to turn. So all those are possible positions from that birthing bed that can accommodate the patient and assist them during their labor and birth. Again, another picture, and this is not how we in the real world how babies are born. Patient's head would never be up that high. I know this may seem counterintuitive. If you think about gravity, you think the higher the patient's head, the faster the baby would come. But if you look, the patient is curled up like a pretzel. Her legs are up and her head's up, and she's kind of folded like this. So how's the baby's head going to come out when she's folded up like that? That's the stupidest picture I've ever seen as far as what we really do. We never put their head up like that. And I've seen people try to do it, and the patient push doesn't happen. So like if you just lower their head on the bed, they will shoot right out. So you lower their head to about 30 degrees, and what happens is then the baby slides under the symphysis. So as this baby's head's coming down right here in this picture, it's banging its head on the symphysis pubis. So if you lay her head down, it'll slide right in. So that's not real life. I mean, that's just a demonstration, but I've specifically put that picture in there to tell you that's not what you'll see. So any of you have seen a birth at the hospital? Have you ever seen anybody sitting straight up like that? No. We usually have to lay them back so the head will slide under the symphysis. If we have a patient whose baby's shoulder gets stuck, the first thing you do is put the head of the bed flat. Because again, you're trying to get the baby to slide up under the symphysis. This is a delivery table. You don't need a lot to have a baby. These are the few things that you need. You need water, bucket of water. You need a bucket in the back to put the placenta in. You need lots of sponges. You need a bulb syringe to clean the baby's nose and mouth. Cord clamp. Here's a tube for blood if you want to get cord blood. Some clamps, some scissors, some suture if you have a tear of some kind that has to be repaired, or if the doctor's done an episiotomy. And that's it. That's really all you need. And that's set up usually right inside the room. Every room has a little wooden table that has all that stuff inside of it. You just open it up. Set it up, and we do set it up in sterile. We set it up as a sterile field because there is suturing done and things like that. Now, again, I think I've told you all this enough that you probably know by now. Vaginal delivery is not a sterile procedure at all. But because we're using instruments, because we're doing repairs, we do set that up as a sterile field. So that is all sterile. This is the baby warmer that is used for the baby. If the baby's doing well when the baby's born, the doctor or midwife will usually put the baby up on mom's belly and then cover the baby with a warm blanket. But if the baby's premature, or we suspect things are not going well, or if the baby doesn't seem to be breathing, then they'll bring the baby over to this warmer. And this is a preheated radiant warmer, so we'll turn it on before birth so that it's preheated to 37.0. And then we have oxygen always ready, suction always ready. We have everything that we need at the baby's bedside for positive pressure ventilation if necessary. There are little tiny ET tubes in the room this big, and laryngoscopes, and so we've got everything we need in case of an emergency. Hopefully we don't need that. Again, if all's well, the baby will stay on the mom's abdomen for just a little bit, and then we usually will bring the baby over to the warmer after a few minutes so we can do baby's vital signs, so we can weigh the baby, measure the baby, get the footprints put the bracelets on, identification bracelets on the baby, just do those few little things that have to be done, and then we can give the baby right back to mom. Remember, and I'll stress this again in a week or so, but remember, you guys that have me in clinical, what are the 2 tasks that a newborn who just been born has to be able to do to survive? What are the 2 tasks?
Breathe.
Number 1, initiate respiration. Number 2, maintain body temperature. So that's why it's critical that we have a warm place for the baby. If the baby goes on mom's belly, first of all, it's skin to skin, but we do cover the baby with a blanket from the warmer as well. Put the baby in the warmer, we've got warmed blankets. Baby's coming out into a room, he's been in a 98-degree environment in water for months, and now we bring a wet baby out into a 70-degree room. So it's a 30% temperature swing, and he's wet on top of that. So it's really hard for babies to maintain their temperature if we don't support that. By drying them, taking away the wet linens, and then keeping them in a warm area until they can maintain their body temperature. This is an OR. This is a small OR. Our OR is much bigger. But it has everything that you need for, you see all the anesthesia machines, everything you need for any kind of anesthesia. And then baby warmer, which stays in there. And most rooms are bigger than that. But it's a standard OR. The only addition is the stuff that you need for a baby. And if you need to get a baby out quickly, the quickest way, I think I said this on Monday, but the quickest way to get a baby out, if you have to, is general anesthesia in terms of how fast can you get your patient anesthetized. So general anesthesia is going to be your go-to if you're in an emergent place. Even if the patient has an epidural in for labor, they're not going to be numb enough usually for the birth, for a C-section, because we don't want them to be that numb during labor. So if they have to emergently have a C-section, usually they'll end up having to be put to sleep. It's very, very emergent because if we don't have time to wait for the epidural for them to dose it heavy enough for a C-section, then we have to go ahead and put the patient to sleep. There are exceptions to that where they may be able to dose it and the patient's okay, but usually they're not numb enough to have a C-section. Yes.
Yesterday, this is kind of a caveat to that. We talked about if you have a drug mom or a mother who is a heavy pot smoker or something, or just a patient in general, they're harder to get out with general anesthesia. They really got to knock them hard.
Well, especially if they've used opiates, because a lot of the induction agents, not all of them, a lot of them are opiate-based, so they have tolerance.
Right. So
they are
I was with a patient who was getting the procedure, and I was just amazed how much they had to hit him and stuff in order to get him out.
Yes, that is true, and again, most especially with opiates, or even benzos, if they've used a lot of benzos, because those are the 2 classes of drugs that they use. And then they add gas on top of it, of course, but in order to, they first give the patient, opioid-based drugs and benzodiazepines, and yes, it is very hard to knock them out. They can do it, but they got to give them a lot of stuff. And it's about their tolerance. Okay, so this is just a picture of the baby being delivered. Can you look at this baby and tell me what position this baby's head is in? See the ear up here? What position do you think the OP or OA?
OA.
OA, yes. See how the baby's looking? The ear's right there. You see how the baby's looking at the floor? The baby's OA. If the baby was OP, his face would be turned around. He still had fur as OP, but his face would be looking up instead of looking down. Good, very good. Okay, if an episiotomy is done, and for anybody who does not know, an episiotomy is when a little incision is done in the perineal area just to help make room for baby. And there are 2 types of episiotomy. The most common type is the median, which goes directly from the bottom of the perineum down. And then there's another one called a mediolateral, which actually goes out this way. It's extremely painful afterwards if a patient has this kind of episiotomy. Why would they do that? If the patient has a very short perineum, or they're really concerned about a tear, and they don't want this tear to extend into the rectum, sometimes they'll cut this way to help prevent this from tearing and having rectal damage. They'll do a mediolateral. It can be either right or left. Either one can be done. But again, that patient does usually have to fill it down for a week. They're very, very sore. Episiotomies used to be done routinely. Basically, they did one on everybody. And after midwives for years telling the docs that that wasn't necessary, they finally started to listen. And now they hardly ever do them anymore. And I'll be honest, I was one of the ones that was a little bit skeptical, thinking, well, it's going to take forever to get the baby out. It doesn't take much longer. We're not seeing a lot more tears. If there is a tear, it usually ends up being about what an episiotomy would have been. So it's no big deal to repair. What we're trying to prevent is, a little tear here or a little cut here is not any big deal. We do not want it to extend down to the rectum. That's when you start to develop, the patient can develop long-term problems with bowel function, with painful intercourse, other things, when you have those big, long tears that extend to the rectum. So those are bad news. We do not want that to happen.
That would also be like a major infection or spread.
Oh, sure, absolutely. Yes, because they got stitches, they're trying to have a bowel movement, they have to be on stool softeners for weeks, pain medication. And now what's the pain medication do to the bowel function? And then it causes constipation, so it's a mess. It's literally and figuratively it's a mess. So yes, it causes all kinds of issues. And we'll talk more about that when we talk about postpartum. Well, now here we'll talk about here. I can't remember where that stuff was. I thought it was in the next chapter. So second stage of labor at birth of the baby, perineal trauma related to childbirth. So we are going to talk about lacerations. We'll hit on it briefly again in postpartum. The lacerations, if we go back to the previous slide, you can have a laceration. If we talked about going from the perineum down, first degree, second degree, third degree, fourth degree. Fourth degree laceration extends into the rectum. A third degree ends before you get to the anal opening. So first, second, and third degree are just how far it comes down, but it doesn't get to the rectum. The fourth degree is a rectal tear. So you can have a laceration of first, second, third, or fourth degree. Or you can have an episiotomy that's a first, or usually if they cut an episiotomy, they'll do a first or second degree. That's just how far down the perineum it extends. The fourth degree is what we're concerned about because it's a significant tear from the perineum and it goes into the rectum mucosa. It requires a very good and competent repair to prevent problems later. I always used to be worried when they let a first year, intern basically sew up a fourth degree. And it would take them an hour, sometimes an hour and a half to sew them up. And the poor patient's laying there in forever, and you're sitting there forever while they sew up fourth degree, and you worry about they're going to be okay later. But fourth degree extensions into the rectum are worrisome. Most of the time, the patient does fine, but there are again risks of problems with bowel function, problems with maybe even incontinence, problems with painful intercourse. Depending on how the scarring heals, how long it takes to heal, all those things. So that is a very concerning. So you can probably think of, if I were to ask you, if I had time, I would, were to ask you, what are, they named me 4 or 5 concepts of, nursing diagnosis that are pertinent to a woman that has a fourth degree laceration. You think about infection, you think about pain, you think about, long-term function, to think about some other more psychosocial things. There are multiple things that play into that. Vaginal and urethral and periurethral lacerations. On each side of the urethra, sometimes you get what we call periurethral lacerations. From the stretching, you'll get a little tear on each side of the urethra. They usually don't even have to be stitched most of the time. That's not uncommon. It's just from the stretching of the labia and the outside the urethral area. But that's something that you may see. And then you can also have a cervical tear. So remember, the cervix is on the inside. So the cervix is dilating and dilating and dilating. There are 2 things that will cause a cervical tear. Number 1 is the patient pushing before they're 10 centimeters dilated. If they push and they're not dilated, think about that cervix is not fully dilated, but the head's pushing so hard it can literally tear that cervix. The cervix is thin as paper almost at the end. And so you get a tear from pushing before they're fully dilated. That's one of the main causes of cervical lacerations. The other thing is if the baby, if they comes just too fast. There is such a thing as a precipitous labor, where the baby comes super quick, abnormally fast, and it comes so fast it tears the cervix. So what happens with cervical laceration is that it bleeds profusely. it's vascular, there's no nerve ending, so it doesn't really hurt there, but the patient will have profuse bleeding. So after the baby's born, if we see the patient bleeding profusely, the first place we think about is we think about the uterus not being firm, right? That would be the first thing that you would think of. Why is the patient bleeding? Well, her uterus is not firm. But if we massage her uterus and it feels really hard and firm like it's supposed to, then it's not coming from the uterus. It's coming from somewhere else, and then we suspect a cervical laceration. So we'll talk more about that. When we talk about postpartum, we'll talk about more about how to identify a cervical laceration. I just want to kind of introduce it to you and tell you the causes of it. But it will have to be repaired by the physician, and they're very difficult to repair because it gets on the inside. So. All right. Now the third stage of labor, we've moved on to the third stage, which is from the birth of the baby to the delivery of the placenta. And how many minutes is that usually? You may remember? Yeah, 5 to 30 minutes. Good. So after the baby's born, you think, oh, contractions are over. The patient typically thinks that as well. And all of a sudden, oh, here comes another contraction. It's not nearly as significant or painful as labor, but it is a definite contraction. And what you'll see is a sort of a patient will say, oh, I'm feeling another contraction. They see a little gush of blood, and then the placenta comes usually right after that. So usually they put a clamp on they clamp off, when the baby's born, they put a cord clamp on the baby's side of the cord, and then they put a big instrument clamp on the placenta side, and they cut it in the middle. So you've got an instrument clamped down on the umbilical cord, and they very gently, kind of pull a little bit, and then when it's ready to come out, it just gently comes right out. And so you see the lengthening of the umbilical cord as the placenta is delivered. Once the placenta is out, the doctor or midwife examines it to make sure it looks like it's all there. Because you can have a retained placenta. You can have a piece that gets left behind. So if you have a piece that gets left behind accidentally, which is not very common, but it can happen, what problems do you think would arise from having a piece of placenta left behind? Infection number 1. What else? Bleeding. So remember that placenta attached to the uterine wall is what tells the uterus, to pour blood into it. You've got those spiral arteries coming from the uterus that bore into the placenta. If a piece of placenta is still there, it's going to continue to send blood into that. So you're going to have bleeding from the retained placenta. Plus, you're going to have a risk of infection as well. So if they see that when they look at the placenta after it's delivered, if they say, there's a big chunk missing, and when you look at it, you might say, how on earth do they tell that? But, it's just a skill that they learn after a while. They can usually see where a piece is missing. They'll have to go in and manually remove that, and if they can't get it, in the, delivery area, they may have to sedate the patient, take it to the OR. The worst case scenario, they'd have to go to the OR and manually remove it under sedation. Sometimes the patient just can't tolerate that in the labor room. If they've got a really good epidural and they're pretty numb, they might be able to, but they also may not. So if that would be the case, you may see them have to go to the OR for really it's a DNC. You're just afraid for that. You can't waste that off the uterine wall. So here's the placenta as it unattaches. So there's the cord, so it's unattached right there. It's just become unattached. It should be secured to the uterine wall, right? The cord's coming out. Now it's starting to pull, it's starting to come out. There, whoever's the delivery personnel is putting a little gentle traction right there, not pulling on it, but just gently holding onto it to guide it out. And it comes out with the baby side facing out. So this is the baby side, that's the mom side, that's what's attached to the uterus. So it comes out in that manner. And then we just drop it in the bucket, and usually it's disposed of in most cases with medical disposal. If there's an abnormal something going on with the baby, or they're concerned about something with it, they might send it to pathology. They don't do it a lot anymore unless they really have something they're concerned about. But if they don't send it to pathology, it's medical waste. However, there is a company at CAMC now called something like Life something. And they are taking placentas and membranes and using them for research and other things. I can't remember what all they said they were using some of those, the membranes for, all kinds of things. And so they have been coming into the room and asking their patient, can they have their placenta? Would you donate it to us? And usually 9 times out of 10 patients will donate it. What are they going to do with it? So it goes to them, which is nice, but it's kind of sad for me because I used to always go get them, and we'd go to the dirty utility room and actually get to look at them and touch them, but I never get to anymore because they all go to this company. So we don't get a chance to see them up close and personal. It's very interesting to see and actually see it face to face. But pieces of this placenta can be used for a lot of things in research. I'm going to look that up on break. I cannot remember what it is they're using the membranes for, but something really cool, and I've forgotten what it is. But they are donating most of them. Now, do we have patients sometimes that ask to take them home? Yes. And there are a lot of rituals and a lot of things associated with placenta. Some people just want to like plant them in their backyard under a tree. That's fine. That's what they want to do. There are people who believe in ingesting them, the placenta. Now, there's a company where you can have it sent off and have the placental tissue put into capsules. If you want to have it ingested a little more cleanly, there's a company that does that puts it actually into capsule form so that it's ingestible that way. And the theory, why in the world would somebody want to ingest the placenta? Well, the theory is, it's nutritious, it's good for you. So I did a little bit of research trying to figure that out, why somebody would want to do that. And is it truly a nutrition thing? So, all mammals, I think, or most all mammals, after their young are born, they do ingest the placenta. So I did a little bit of research to figure out why that was done. The theory is always, it's for their nutrition. That's not why it's done. The reason why mammals ingest the placenta is to protect their young from, what's the word?
Predators.
People that are not people, but prey, by covering up all signs that there is new life. The placenta is, for animals, they can smell it from miles away. They know there's little baby something somewhere, and so they come after them. So by getting rid of it, they dispose of all the evidence and help protect their baby. So that's why mammals do it. Do we need to do that? No. I think not. I don't think anybody's coming to their baby because there's a placenta laying around. So there is really no logical reason for ingesting a placenta. Mammals are not doing it for their nutrition. They're doing it to protect their young.
Is there stem cells, or is that just in the cord? I think I know they're using the stem cells for cancer.
Oh, yes.
Research.
Yes. And as a matter of fact, I'm glad you said that because we are having a lot of patients now who come in with these kits that they want the cord because they are saving. You can save the stem cells for your family. Costs about $1,500, and then there's a monthly fee. But the doctor and the nurse collect it for you, package it, and then send it off to whatever this company is. They store it for you. Then if, let's say you have a child with cancer or leukemia or whatever, or someone in your family, it can be tested with their stem cells to see if it's a match. And if you ever wanted to use that, it would be available.
So basically, that's a jump start of your immune system. I mean, when you get zapped, they kill your immune system and they inject you with the stem cells. They create, brand new.
Yes. So, in case anybody in your family would ever need it, we are seeing a lot more patients come in requesting that, and they have they've contacted the company already. They have their little kit. The nurse and the doctor collect the cord and send that in. They separate the stem cells, and again, there's a monthly fee that the patient pays to this company to keep them with it. And then if you ever need them, they're there. So we are seeing a lot more of that, yes, than we ever used to. So that is a thing. So after the placenta is born, delivered, out, whatever you want to call it, that takes us into the fourth stage. The fourth stage then is from the delivery of the placenta and 2 hours after. So I told you already that 2 hours after is really important in terms of watching for complications. If a patient's going to hemorrhage, that's likely when they're going to hemorrhage. So we're going to watch them very carefully. We're going to assess the fundus or the top of the uterus every 15 minutes for the 2 hours and make sure that their bleeding's okay and that their fundus is firm like it's supposed to be. after birth of a baby, if we feel the top of the uterus and the fundus, it should feel like a hard rubber ball. If it feels soft and mushy, we're in trouble. It should feel hard as I don't know, like a grapefruit under your skin. You know, it almost feels like that. Very, very firm. We'll also do vital signs every 15 minutes as well to make sure that we aren't seeing any signs of hypovolemia. We'll be watching for that. If they have an epidural, they'll take their epidural out. Once the placenta's out, they'll, the patient's down out of stirrups and back put together. They will take their epidural out at that period of time as well. So we already talked about care of the placenta. We already hit on that. Traditions and stem cell banking, all those things, which we've already discussed. So, okay, I'm kind of getting ahead of myself. 15-minute fundal check and fundal massage. And the bleeding that we see after birth is called lochia. When we talk about postpartum, we'll talk about the different types of lochia. That won't be on this test. The kind of blood that is after birth is called lochia. It contains more than just blood. So Q 15-minute vital signs, Q 15-minute fundal checks. If the patient, whether they've had an epidural or not, they still need very vigilant bladder assessment. First of all, if they have an epidural, we've given them tons of fluid, right? They've got liters of fluid, maybe 3 liters of fluid over the course of their labor, maybe 4. So they're definitely going to be peeing a lot. So they had an epidural, they can't feel a lot, so if they either have a Foley or they have to be straight capped until they get the sensation back. But even if they didn't have an epidural, sometimes edema and trauma to the perineal area will keep a patient from being able to pee. They may have enough swelling in that area that they still might not be able to pee. And if that's the case, we may have to straight cap them as well. If they get up and go to the bathroom and they pee 125, don't assume that they're empty. I've seen patients pee 125, 150, another 700 in there. So you've got to assess their bladder. Now, I know on most units, you all do bladder scans, and that's great. I guess OB is just old-fashioned. We've learned I can do a bladder assessment with my hand, and I can almost tell you how much is in there based on how distended the bladder is. So most of the time in OB, they just manually assess that. If it feels distended, they cap the patient. They have standing orders to do so. But it's important to keep that bladder empty because a full bladder will push the uterus. If your bladder fills up, it will push the uterus up and over to the side, and it will keep your uterus from being able to stay firm like it's supposed to, and it actually can contribute to a hemorrhage. So a full bladder in a post-delivery patient is very dangerous. So bladder assessment is very important. Talk about removing an epidural catheter. We'll assess the patient's sensation and mobility at that time, but they're certainly not going to get in a wheelchair an hour after they've had an epidural. They may have some sensation back, but it won't be enough that they can go get popping down the hall. Care of the new mom and baby. Certainly we want to, if we haven't already, initiate skin-to-skin contact, initiate breastfeeding if the mom's breastfeeding, and we'll continue to assess the newborn with concern to respiratory status and body temperature. And then this is the time where the family come in, visit the baby, mom, dad, papa, mama, whoever, come see the baby, feed the patient while we continue to monitor them, and then after an hour or two, they'll go to their new postpartum room. This is the recovery period. Now, I said skin-to-skin contact. What if my mom's temperature is 102.5? Do I do skin-to-skin contact then? No, because I can't overheat my baby too. We don't want our baby to be hyperthermic. So you would never do skin-to-skin contact with a mom who has a fever. That's contraindicated. She can hold the baby, but we're not going to do skin-to-skin with that in that situation. All right, the nurse would assess the laboring woman into a hands and knees position when, what's your answer? Anyone hazard a guess? Okay. That's correct. When the baby is occiput posterior, the best way to get the baby to flip is to get the mom on hands and knees with her chest down or bottom up even, if you can. That's the best way. Leaning over that birthing ball or something to that effect. That's the best way to get the baby to flip. So now, problem is if she has an epidural, can we do that? No. If she doesn't have an epidural, by all means, let's try to do that. Get the baby to flip. so that the baby is in a position where the diameter of the head is smaller and it passes through the anal spots. Good, okay, so take a 10-minute break and then we'll start chapter 17.
Already taken an hour break. TikTok yesterday, and I was this lady. Relationship with people. She said whatever we get through. TikTok yesterday, and it was like this pregnant girl, and she